Good afternoon, everyone. My name's Maria Sade. I'm the CEO of Allergy and Anaphylaxis Australia and the co-chair of the National Allergy Strategy. I welcome you all to today's webinar and panel discussion. The focus today is breakthrough the burden of cow's milk allergy. Many of you would have seen the QR code on the first slide. We'll bring it up again for you now. The QR code can be scanned so that you can partake in the polls and the live Q&A this afternoon. The poll questions will assist us with knowing where people have joined us from today. So I ask you to please respond, and we'll then share results. And the second poll question is just for us to understand a little more about who is joining us today. So what health professionals have we got on today's webinar? The webinar today will be recorded and made available to all that have registered. So keep an eye out for that email. The questions that are going to be asked today will also we'll have a panel discussion with 4 guests that I will introduce in a few moments. And the questions will be posted once they're answered and sent to you by digital means. So please keep an eye out for those. Now, I'm just wondering what's happened with the poll questions. Hopefully people are seeing those and responding. I can see now that we have 23% of people from WA and Victoria and South Australia. Oh no, sorry. 15% of people are joining from New South Wales, 8% from the ACT, and I can see, 14%. Thank you. We can see more people are responding to this poll question now. We can see results there. So we can see that majority are from New South Wales, Queensland, WA, Victoria, and numbers are a little lower from the Northern Territory and the ACT, which is be expected, and 13% from New Zealand. So thank you for sharing that information with us. I think there was a second question that you will be responding to now. Sharing your profession or your area of healthcare is important, because then during the panel discussions that will be had, the experts will be able to hopefully tailor the responses to meet the needs of the people who are on the webinar this afternoon. Here we have the second polling question. So what is your profession? We have lots of dietitians on, which is great. So thank you for joining us. There's certainly a lot more that needs to be understood about cow's milk allergy. And certainly from a consumer perspective, many people who have cow's milk allergy, a child, an infant with cow's milk allergy, need lots of support and lots of guidance from dietitians. So it's great to see that we have some paediatric allergists on, so a few general practitioners, and I can see some 14% of people fit into the other category. So it'll be, it's good to know that most people on are dietitians with some allergists and general practitioners and other health professionals. So thank you for sharing that information with us as we move forward. So today we'll be listening to some pre-recorded sessions of 4 experts in allergy. The first will be from Professor Gary Wong from Hong Kong. He'll be speaking with us about living with COVID, what has been the impact of the COVID pandemic on paediatric food allergy. Now, I'm sure we've all experienced challenges. I know I certainly have in my role in supporting individuals with cow's milk allergy through, or any food allergy, through the COVID pandemic. And it's not over yet. But it'll be interesting to hear what Professor Gary Wong has to say. I will then introduce the other speakers, who are Dr. Roseanne Meyer from the UK, Dr. Rebecca Stratton from the UK as well, and then Dr. Vicky McWilliam, who is at the Royal Children's Hospital in Melbourne. So as we kick off, I'd also like to actually introduce our co-hosts for this afternoon. I've introduced myself. I'll now introduce Kathy Beck, who's a paediatric dietitian, and Kathy is also the chair of the ASCIA Dietitian Committee. Professor Pete Smith, well-known researcher and clinician from the Gold Coast and Brisbane, clinical allergy immunology specialist, and Dr. Elizabeth Pickford, who is a paediatric allergist, has worked in allergy for many, many years. These experts and I will we'll have a discussion after each of the presentations, hopefully responding to the questions that you put through whilst the presentation is happening. So as an intro, I'd like to speak on, just for a couple of minutes, on why allergy is on Australia's political agenda. Allergic disease affects at least 4 million people in Australia. Food allergy affects 1 in 10 babies in Australia. Some of those babies will outgrow their allergy, but many will hold on to their allergy. Living with allergic disease is not easy. It really affects your quality of life. Allergy and Anaphylaxis Australia has been visiting Canberra and speaking to politicians since the early 2000s. Allergic disease is an Australian public health issue. We are not named the food allergy capital of the world for no reason. Look at the rates of eczema we have in Australia, allergic rhinitis, allergic asthma. It is not just food allergy that's the problem, but that is our main focus today, will be cow's milk allergy. However, we need to understand that allergic disease affects not only individuals, but often families. Rarely do you find a person that has only got one allergic disease, and many have multiple allergic diseases, and families often have multiple people with multiple allergic diseases. Allergic disease is complex. It is not clear-cut. It is not simple. And we have an epidemic of allergic disease in Australia. It's on the political agenda because this is a public health issue that needs attention, just like diabetes, just like heart disease, just like other acknowledged public health issues. Allergy and Anaphylaxis Australia and ASCIA, the peak medical body, the Australasian Society of Clinical Immunology and Allergy, set out to Canberra in 2013, 2014, and we were told by the government that if we worked on a strategy for the management of allergic disease to improve allergic disease management in Australia, and we presented that to the government, that the government would hopefully acknowledge and help us move forward with allergic disease. We did that. We partnered. So ASCIA, the peak medical body, the peak consumer body, partnered in 2014, and we then liaised with many key stakeholder organisations, and with them we created a national allergy strategy. We looked at where the pitfalls were in allergic disease, where we needed to do more work, and the national allergy strategy was launched in 2015. In 2019, by this stage, we had received some government funding. An inquiry, a parliamentary inquiry into allergic disease, into allergies and anaphylaxis, was announced by the Health Minister, Greg Hunt, and Trent Zimmerman, MP. That public inquiry that occurred just before the pandemic was amazing. We had more than 250 submissions put in to the parliamentary inquiry, and there was also some public hearings around the country. Allergic disease does not discriminate. Everyone is affected by allergic disease, whether it's through a child at the school that your child goes to, whether it's a family member, a friend, and allergic disease is chronic disease. Rarely is there a cure for any allergic disease state. So it's really important that we see allergic disease as a public health issue. It is on the political agenda. The government, the outgoing government in March 2022, did put down $26.9 million to transition the national allergy strategy and a national centre of excellence for allergic disease. And we are waiting for the government, the current government, the Australian Labor Party, to move us forward so that we can execute the response to that bipartisan parliamentary inquiry that was announced in 2019, and the response from the committee that was then passed on to the Health Minister. On that note, allergic disease is something that we all need to be aware of, and I just want to thank everyone who's joined this webinar and panel discussion this afternoon to help us move allergic disease forward to improve the quality of life of people with allergic disease across Australia and New Zealand. So moving through to the next slide, I'd now like to introduce the first speaker. And the first speaker, a pre-recorded session, will be Professor Gary Wong, who's a professor and honorary consultant in the Department of Paediatrics, the Chinese University of Hong Kong.
Thank you very much for having me to join this symposium. And the task given to me is to discuss about living with COVID. What has been the impact of the COVID pandemic on pediatric food allergy? And I'm Gary Wong from the Chinese University of Hong Kong. Now, of course, all of us have gone through this tremendous problem of pandemic so far over the last 2 to 3 years. With all these measures that we have encountered, particularly for children, they don't go to school And for adults and children alike, because of the limited business hours of the restaurant, most children and a lot of adults stay home most of the time. And when they do go out, there are a lot of social distancing measures. And on top of that, there are a lot of so-called personal hygiene measures that we, well, in the past, really would not do all that kind of things. We was rubbing our hands, cleaning our environment constantly with all kinds of disinfectant. And of course, there are also increased use of a variety of drugs that primarily for the use of potential infections. And I'm sure many of you have been buying a lot of cleanser, disinfectants, and bleach for use at home or at work. Now, all these measures actually would have profound effect on the environment. And of course, when there are changes in the environment, that also changes the microbiome that exists in any individual. And in particular, for children, the early immune system, they interact with all these environmental microbes such that the immune system would develop properly. Now, because of all these changes, they're going to drastically change the immune response. Now, if one look at the immediate effects of the pandemic on patients with allergy. Now, of course, we can look at respiratory allergies first, whether it's allergic rhinitis or asthma. And we know over the past 2.5 years, there is actually a paradoxical response, or I should say paradoxical improvement in the level of control in asthmatic children. And it's highly likely that most asthma exacerbations actually are related to viral infections, particularly in the pediatric population. And also on top of that, a lot of children, because they don't really want to go to the hospital, and as a result, they tend to have better adherence to the asthma medication. And furthermore, because a lot of people stay home for their work, and there is also reduction in traffic related to pollution. Now, all these reasons contribute to the improvement in the care or in the control of asthmatic children. Skin allergies, in particular for atopic eczema, it's a little bit different. Now, as you can imagine, the repetitive use of hand cleanser would actually very often dry out the skin and cause more troubles for patients with eczema. Now, patients with food allergy are slightly different. Now, one has to remember a lot of accidental exposure to food allergens resulting in severe reaction very often happens when adults and children are eating outside at a restaurant. But of course, because of these pandemic measures, children are more likely to stay home. As a result, those type of accidental exposure become less often during the pandemic times. Well, one very important measure also is, now, when children develop food allergies, or maybe there is new cases of potential food allergies. Now, the diagnosis of food allergy is a bit more difficult compared to the diagnosis of allergic rhinitis and diagnosis of asthma. Very often, one would need a little bit more, for example, like skin testing or food challenge to confirm the proper diagnosis of food allergy. And of course, during pandemic times, because of a variety of restrictions, including a variation in the degree of lockdown, the access to healthcare may be limited. Now, as a result, new cases of food allergies, there may be a delay in proper diagnosis because there is delay in access to proper healthcare. Unlike the treatment or management of asthma, one can do a telemedicine type of consultation. But really, to manage food allergy, to do the skin testing, to get the blood to measure the IgE, and also to do the food challenge, it cannot be done over the internet. So as a result, it may cause a little bit of problem for those with potential new case of food allergies. And in fact, there has been study looking at parents with children with food allergy. And this study just published a year ago assessed the anxiety level of parents with children, young age, 0 to 8 years of age, with known food allergy. And in this study is a case control comparison with a total of 580 patients, or subjects, I should say, 32 of them with allergies compared to the control population. And here, among these 32 cases of children with food allergy, of course, one would expect the top 3 food allergens are milk, peanuts, eggs, and the others are tree nuts, fish, wheat, soya, and fruits. And there are 2 scale or 2 measurement tools that the researcher used to assess the parental anxiety level. Those who are under 1.5 years of age, they use the parental anxiety screening scale, a total of 14 cases. And for those over 1.5 years of age, they use a generalized anxiety disorder 7-item scale score to evaluate the 18 cases in that age group. And the results, well, in the younger age group, the 0 to 1.5 years of age, they did not find any difference in terms of the anxiety level in the parents. But for those parents with children aged 1.5 to 8 years of age, what they found in terms of anxiety score in the control is 6.99, while in the cases, they were 10.33. And among them, more than 10 is considered an abnormally high anxiety score. And among these 18 parents with children with food allergy, actually about 1/3 of them had a score above 10. And the difference, statistically significant between the control and the cases. Suggesting during the pandemic times, for a variety of reasons, parents with a child with food allergy tend to become a bit more anxious. And these are the qualitative assessment of what the parents feel. There is, as you can read here, some parents will mention, I feel stressed out and anxious about going to the store, maybe because of the limitation of the type of items available at the store. And then there are also mentioned, it is harder to find the proper baking products in order to reduce the chance of, accidental exposure to other type of allergens. But also, there are also parents saying, before we are always on the alert. Now, probably because of the fact that they are going out much less often. So usually within the home environment, the parents are in better control of what the children are exposed to. Now, of course, there are the difficulties of those children who may need treatment, such as oral immunotherapy, OIT, for the management of food allergy. And one parent mentioned, my child was supposed to start on the OIT, the oral immunotherapy treatment, which helped to reduce the severity of accidental exposure to the food allergen. But of course, because of the pandemic, it delayed the onset of starting such treatment. Now, sooner or later, we know the pandemic will end. But all the measures that we're doing currently actually profoundly change the microbial environment that surround the young child. For example, the use of more antibiotics for presumed infection, The various hygiene measures, social distancing, frequent hand washing, all would reduce both virus and bacteria in the environment. And pet exposure, you may have heard of some of the outbreaks that COVID actually can infect certain pets. And in this case, actually, a hamster actually can get infected. And with the feeding practice that has also been changed during the pandemic times. In particular, parents tend to be much more careful or much more clean per se in terms of handling, the utensils as well as cooking the various ingredients. And there are also, in certain places, there has been an increase in the rate of cesarean section, which we know actually would result in the early exposure of microbes for the baby, very different from a normal vaginal delivery. Now, all these factors will shape the microbial environment, particularly on the skin and as well as in the GI tract of these young children born during the COVID times. Now, all these measures will result in an excessively clean environment. And in particular, when the environment is clean, it usually would affect the gut microbiome. And we know the gut microbiome play a very important role in communicating with the immune system through the GI tract. And right now, what we really don't know the fact that what are the important microbes? When would be the most important time for exposure? Where do children get exposed to these microbes? And what are the underlying mechanisms that these microbes, in terms of their interaction with the immune system? And all these factors actually not properly stimulated immune system will result in an immune system which tend to push the children towards the development of more allergies. And in terms of allergic conditions, we know that in developed countries, the prevalence of a variety of allergic conditions, be it allergic rhinitis or asthma, are more common than in developing countries. Also, people from the urban environment tends to have more allergic disease than those in the rural environment. And a couple of years ago, we decided to look at data related to food allergy. And what we found, there are very limited data, unlike asthma and allergic rhinitis. Food allergy data from the urban and rural environment, and also food allergy from developed versus developing countries are actually very limited. A few studies that we can find suggest that food allergy is rather uncommon in developing countries. And that's why we embarked on a larger scale study called the EuroPrevail study, that we were responsible recruiting children from China, India, and Russia to evaluate the prevalence of food allergy. And compared to the data from EuroPrevail, as the word suggests, it's a study in Europe looking at prevalence of food allergy. As you can see here, we have recruited a large number of children from different cities, including the highly urbanized city of Hong Kong, and slightly less urbanized compared to Hong Kong is Beijing, and also rural environment in Beijing. Guangzhou is a city about 200 kilometers away from Hong Kong, also a city in southern China. Rao Xiuguan is a rural village, which is about 250 kilometers northwest of Hong Kong. And we have also recruited children from India and also Siberia, Russia, and a total close to 50,000 children. And to cut a long story short, what we did, we recruit these primary school children between 7 to 11 years of age. We evaluate them by questionnaire and ask them to see whether they have symptoms suggestive of food allergy. And subsequently, we recruited cases, those who say they have food allergies, and control those they say they do not have food allergy. This child is skin prick positive to peanuts or IgE positive against peanut. Now, as you can see here, for Hong Kong, the prevalence of probable food allergy is the highest among these cities and countries. It's about 2% in Hong Kong. While in China, it's less than 1%. In Tom's Russia, it's about 1%. And food allergy is practically non-existent in the two cities that we recruit children from India. Now, as you can see here, the more underdeveloped or more rural places, you will see lower prevalence of food allergy. Here, we specifically look at the Chinese data in terms of the sensitization rate against cow's milk protein, looking at the serum IgE level. Depending on what cutoff we use a lower cutoff, 0.35. You see the prevalence in Hong Kong, Guangzhou, and then the more rural area. So there is a gradation. The more urbanized center will have higher sensitization compared to the relatively rural area. Now, there has been a lot of study looking at the relationship of microbiome to the development of food allergy and allergic disease. And the fact is, when there is limited animal exposure, in the gut, there tends to be less Bacteroides and bifidobacteria, while there is more Clostridia, which tend to be associated with increased risk of asthma, allergic rhinitis, as well as eczema. And there is a variable relationship in terms of these bacteria and the risk of development of food allergy. But in general, it's very consistent that whether it's a cesarean section or the decrease in number of siblings or the use of antibiotics during the perinatal period, it tends to result in a gut microbiome with more of the what we call the bad bacteria, such as Clostridia, and there is less of the good bacteria, bifidobacteria. There is an ongoing study right now in Germany looking at the use of farm milk. And you will recall the consumption of farm milk or unpasteurized farm milk in the rural environment is strongly related to the protection of the development of allergic disease. So this trial is testing whether the use of the minimally modified farm milk, which tend to have a lot more microbes for the young child, it may possibly lead to the change in the gut microbiome, resulting in a more favorable environment, protecting the children from the development of allergies subsequently. So what we can expect, what's going to happen during and after the pandemic. Now, there are several ongoing studies, including the cohort studies that we are conducting. We obtain samples of fecal microbiome analysis from our babies, and we're looking at the detailed changes of the microbiome in the gut of those babies born during the pandemic and those babies born before the pandemic. And our early data suggest, that actually we can predict by looking at the early fecal microbiome of the children, which will help us to predict the subsequent development of eczema. Now, studies on food allergies are a little bit more difficult because there are many other factors that may play an important role in affecting subsequent food allergies. For example, the timing of introduction of solids and the dosage of exposure, and also the route of exposure also affect. For example, skin exposure to food tend to cause allergies, while early GI exposure tend to give you a protection. And of course, diagnosis of food allergy is a bit more difficult compared to the diagnosis of eczema. But we will follow these children and evaluate them to see the development of food allergy. And one would anticipate, alongside with increased asthma and eczema in those who are born and raised in a clean urban environment compared to a more rural environment with a lot more microbial exposure, one would expect all these changes affecting the gut microbiome may have an effect on the subsequent development of food allergy. So in conclusion, now food allergy has been described as the second wave of the allergy epidemic after allergic rhinitis and asthma. And it appears that food allergy is relatively uncommon in developing countries right now. But of course, there are marked variation in the prevalence and types of allergens, particularly in Asia. An accurate diagnosis of food allergy is a major problem, making research in this area a bit more difficult. And all the hygiene measures we know of, the COVID prevention strategies, that they're all associated with a change in the various microbial environment. And all these microbial factors can shape the early development of the immune system. And one anticipates the COVID generation actually is exposed to a very different environment in their first 2 years of life. And these differences in exposure may result in change in the gut microbiome. And with that, alternation of the gut microbiome may be associated with increased risk of development of allergic disorder, including food allergies. An understanding of these microbial factors and understanding how these factors interact with the early immune system will provide very good insights for us to develop future primary preventive treatment for our allergies. And many researchers are asking, could manipulation of the microbial environment would result in immunomodulation leading to what we would like to achieve, which is primary prevention? And thank you very much for your attention.
Okay, that was a really interesting presentation by Professor Gary Wong. Certainly did put forward some issues around the effect of the pandemic on management of food allergy. I'd now like to move through to our panel discussion. I remind people that if you haven't scanned the QR code, please do so, or follow the link at the bottom of the screen so that you can ask your questions through the Q&A function. Please send them through. Maybe some comments on how the COVID pandemic has affected you in your practice, in your management of allergic disease. We might just speak to the expert panel now and ask some questions on how we all managed the COVID pandemic and whether some of the points that Professor Wong put forward were the experience of allergists Pete Smith and Libby Pickford. Maybe you can start off, Pete, just share what the challenges were for you, and then we'll speak with Kathy about, from a dietitian's perspective, what impact there was on the challenges of telehealth and managing from a dietetics perspective. So, Pete, over to you.
Certainly. Thank you very much, Maria. That was very interesting from Gary. We certainly saw more cases of hand dermatitis with overwashing, sensitization to contact allergens like Kathon that's used with these types of products, which then goes on to affect use as everyday products. So they become sensitive to washes and shampoos. We also saw far more food allergy anxiety. That definitely increased, and I think just hearing kids being at home with parents leaving the news on with bad news and reporters yelling at people just does, brings the whole vibe down. And also, I'd throw in that Irish studies have reported recently increased dermatitis, but also increased sensitization to food allergy. And we know that stress increases the tight junctions in the gut, so it opens up with both acute stress and chronic stress. So if people if people are stressed, we know they're going to show more signs of food allergy and react to foods that they wouldn't have it react to as well. But also, it just doesn't it affects us probably in the risk of sensitization as well, and also people being indoors, not getting their vitamin D, not getting the fresh air that's so important to our microbiome.
Yeah. And look, from my perspective, on the flip side, looking at the from the consumer's perspective or the person with food allergy, the families managing food allergy, we also took a deep breath because the world was realizing just how careful we needed to be about avoiding something. So that was a positive from a a person managing food allergy perspective. So I understand it was increased stress because we had difficulty accessing food. The limits were an issue. We had people in hotel quarantine with food allergy. That was a huge issue. But one of the positives, if we can call it that, and there were many, many, many negatives, was that there was a better understanding that people had to be so careful of avoiding something. So avoiding COVID, there was some synergies with management of food allergy. I'll just put that forward. Did anyone else have any patients or people comment back on aspects? Libby?
Not as such, but
Mm-hmm.
I can say how it affected my particular practice was that we moved to telehealth, and that was initially met with a reluctance by parents to actually participate at all. I think everybody wanted skin prick testing, and it was something that couldn't readily be offered. And so, the alternative was, we'll do a catch-up skin prick test later, and I'll get back to you about how that fits in with what we talked about, and then we'll make a plan of where to go. Or they could go to blood testing, but parents didn't generally want to do that because nobody wanted to go to pathology centres to get anything done. So that made that difficult. And I think the other thing that was made quite difficult was that there were no oral challenges available, in that, if the diagnosis was in question, you couldn't confirm challenge. And also it was hard because some food challenges are there to see if somebody's actually outgrown their allergies, and so they can let their guard down just a bit. So, we couldn't do that either. So, that made it quite difficult. And then to the question of, how many reactions did we see? I think, yes, the comment that Gary Wong made about there being less people going out to restaurants and schools and so forth and eating outside of the house, that's true, but there were still lots of mistakes made at home, often by people, adults in the house who weren't totally familiar with how to manage food allergy. You get one person who's in charge generally, and the rest of the family kind of stays away until they think they're being helpful, and they're not. So that sort of came up quite a bit, usually with the excuse of, I didn't know, you didn't tell me, or I didn't think, none of which cuts it with me.
Yeah. So it was, different people doing shopping or, ordering food in, and the usual checks being missed because, the pandemic became was at the forefront of everyone's mind. Another thing that I found too is that we did hear of some instances where people had reactions. This is when we started, seeing an increase in hospitalisation. People would administer adrenaline, but not necessarily call 000 for an ambulance. So that was a little bit frightening too. So they wanted to protect their person that's had anaphylaxis at home rather than the potential exposure to COVID in a hospital emergency department. So, there were a lot of changes that we had to deal with. And when I say we, I think, the whole allergy community, and just education on simple aspects such as hand sanitizer doesn't remove food allergens from people's hands, for example. It might remove bacteria, but it doesn't remove food. So we were educating people every step of the way. And at the same time, I hear what you're saying. There was a lot that you couldn't do in your clinical practice because of the restrictions placed on us. And that has created a whole mountain our waiting lists now for food challenges across the country are astronomical. And, so are our face-to-face appointments. So, that's really been an issue. Kathy, do you want to share sort of the challenges that you had as a dietitian and how you managed that during, I guess, during the lockdowns, and then, how do you catch up on that,
Well,
people on that wait
overall
list?
overall for us as dietitians, it was a lot easier because the one thing that we actually need is we need growth data, because most of my patients are infants and very young children, and so growth is probably one of the most important sort of things that I need to monitor. And so usually a GP would still be able to weigh and measure a child. So I'd usually say, so long as we can have up to date growth, parameters, that's great. And so from that sort of perspective, it was okay. What I did see a lot more of is mothers of babies born during the pandemic who couldn't have anyone visit them in hospital, who then babies then subsequently developed food allergy. They didn't have a lot of support, like families couldn't visit from interstate. People weren't coming around. And so the parental anxiety in the group of patients that I was seeing, that some of them had FPIEs, some of them had multiple food allergies. And I think that, they're always a very anxious sort of population, but I think because of the lack of support and the lack of communication with other family members, I think that was really, it's something that I quite noticed during COVID. On a positive note, I think a lot more families were cooking at home. And so there was a lot more demand for home recipes. And, so part of my role is I teach people how to cook food for babies. It's one of my pet things. A lot of people don't learn how to cook, of the younger generation. And teaching just basic cooking skills was something that I did a lot more of during COVID. And I think the other thing that I noticed is that most families used online shopping to get things delivered. And so, as you mentioned earlier, they actually couldn't check the ingredients as easily, as readily as they normally did. And sometimes the online shopping, supermarkets didn't always supply the exact product that they had said. So there was a few issues like that, I guess, but not really that much. Yeah.
Okay, thank you, Kathy. Our discussion time has come to an end, and it's time to move on to our next speaker. There was a question that's come in. I just say to that person, we will certainly keep that question and add it to the write-up of questions, or we may ask it a little later. I'd now like to introduce Dr. Roseanne Meyer, who is a paediatric dietitian and honorary senior lecturer from Imperial College, London, the UK, and also from Leuven in Belgium.
Thank you very much for the kind invitation to speak on a topic that's very dear to me. That's cow's milk allergy, immunity and infection. We have over the years seen so much emerging data on this very exciting topic. I'm Roseanne Meyer. I'm a pediatric dietitian. I specialize in food allergy. I straddle several countries. I'm honorary reader at Imperial College, where I lead the food hypersensitivity module for our MSc in allergy. And I'm also visiting professor at University of Winchester and KU Leuven, where I straddle other areas of pediatric nutrition. What I'm going to start off today is just share my disclosures, which primarily cover academic lectures like this, and I'm also part of 2 allergy boards. I'm sure many of you know the prevalence of cow's milk allergy, but it's a really good starting point. For us in Europe, we use the Europreval study because it's quite a robust study of 12,000 infants of challenge-proven children with cow's milk protein allergy. This study really straddles a huge variety of patients from different countries, and you'll see a variety and range of prevalence of cow's milk allergy. You'll see with the United Kingdom, we have the highest level of cow's milk allergy, around 1.3%. And in the UK, you'll see that the IgE and non-IgE mediated cow's milk allergy is very similar. Now, when you look at the prevalence, you'll see it's 0.59, but there is a huge range which has been highlighted by the British Society of Allergy and Clinical Immunology. These are also studies that are robust and based on double-blind challenged cow's milk allergy patients. And you'll see it ranges between 1.8 and to 7.5%. I think most of us think that cow's milk allergy, if we look at IgE and non-IgE mediated allergy, is between 3 to 4%. I think a lot of the criticism, and something that we need to be aware of, is that most of the prevalence studies are based on IgE mediated allergy. And that's also been recognized in a lot of the criticism for the Europreval study, is that it's clear for in some of the countries that non-IgE mediated allergy is under-recognized. Now, all of you know the very well-known symptoms. If you look at the list of symptoms, you know the very well-known skin symptoms, gastrointestinal symptoms, respiratory symptoms, cardiovascular symptoms, and of course, the more systemic symptoms. However, when we talk to each other as food allergy specialists in different domains, many of us recognize that in our population we see more infections. I see children with ear infections with cow's milk allergy, gastrointestinal infections, respiratory infections, and also skin infections. The problem here is, of course, we as practicing healthcare professionals see this quite biased. And so what we set out to do was to develop a study, and I was very fortunate to be involved in this study together with Katie Sorensen and a wonderful team that looked retrospectively in an observational study looking at children with cow's milk allergy compared to healthy controls. Now, this is a retrospective observational study that makes use of the THIN database. What is the THIN database? The THIN database, at the time of collecting this data, contained 2.9 million longitudinal patient records from 365 GP practice, so it's a primary care database. and it's based on coding, of course. So you have different codes for cow's milk allergy, for feeds, and all of those type of factors. In order for this database to be robust enough, we of course needed to have really good inclusion and exclusion criteria. The strength of such a database is in the numbers. And so you can see we've almost recruited within this database almost 3,500 children for each of these cohorts. In our inclusion criteria, we had both boys and girls, and we used the read code for cow's milk protein allergy. But of course, many children will not necessarily have that read code, but they will have a prescription of a hypoallergenic formula. Within the hypoallergenic formula, those that are prescribed are, of course, extensively hydrolyzed or amino acid formulas. So we included children that were prescribed these formulas below 12 months of age and for more than 3 months, so 3 months and more. We also wanted to have a complete database, and we recruited those patients and continued to follow them until 4 years and 11 months. Now, you will absolutely say to me, but Roseanne, there are many other populations that would need a hypoallergenic formula. And for that reason, within the exclusion criteria, we try to capture all of those gastro patients with intestinal failure, or where there might be dysmotility, or for those children, like, for example, cerebral palsy, where you might have gastric emptying problem, where you would need a hypoallergenic formula. So by excluding those patients, we hope that we did not include any patients that did not have a cow's milk protein allergy. But when you read the study, that of course is a limitation. There might be a couple of patients. But in any case, these type of database studies, the strength is in the numbers. And what we really set out is to look at the wider clinical burden. The data that we got was really so interesting and confirmed a lot of our clinical practice. We found a significant increased number of GI, skin, respiratory, and ear infections. And these are the different infections that we included. So from viral to bacterial, gastroenteritis. We also included Campylobacter, GI infections, diarrhea, vomiting that were caused by suspected infections, skin infections that included skin and subcutaneous tissue infections, upper respiratory tract infections, acute tonsillitis, and of course, ear infections, including otitis media, infective otitis externa, and ear pain. And you can see really that in the group that had cow's milk allergy, there was a significantly higher number. The question that you may ask is saying, this is very interesting, but has this been reported in other studies? In terms of ear infections, there are several studies. I'm highlighting one that is quite robust. It's already produced in 1999. It's a Finnish study based on 108 children who had public insurance. They have a national database here with documented cow's milk allergy, and they only recruited those patients with a challenge confirmed cow's milk allergy that were still within the area. So those were 56 children. They were invited for a review, so a face-to-face review, and they also had a questionnaire reported. At the end, they had 56 children. They divided them into children with a cow's milk allergy, of course, compared to healthy controls, and those with cow's milk allergy and no respiratory atopy, cow's milk allergy with respiratory atopy. And already at that stage, they found that those who had cow's milk allergy with respiratory atopy had recurrent otitis media, also more adenoidectomy for air problems, and tympanostomy as well. There are many other studies that have been produced since then, and there was in fact a systematic review on recurrent ear infections in 2021 by Soares de Oliveira. And you can imagine, because there was such different methodology and the heterogeneity of the population, it was impossible at that stage to be able to to put the data together to get one answer from a systematic review. However, I think what is important is that there was sufficient studies to say it warranted a systematic review. And I think that's an important message, that there are other studies that report this association with middle ear infections. What about respiratory infection? Now, there are many retrospective studies, and we are one of the databases that report an increase in frequent respiratory infections, defined as more than one infection per month. So that's actually quite a lot. And we found it in our non-IgE mediated population, in almost 70% of that population. That has also been shown by other studies, also retrospective. I wanted to show a prospective study by Simprani in 2006 on 117 children who were allergic. And I want to say that the allergy here is a more the environmental allergies. But within this population, as you can see, older population, they had a prospectively higher level of respiratory infections. This was also discussed in a wonderful review paper done by well-known world leaders within food allergy to talk about the early life respiratory infections and cow's milk allergy. Now, all of us acknowledge, like this paper, that there is limited data on the prevalence and severity of infections in infants with cow's milk allergy. So some studies have reported higher rates of respiratory infection, but many of them are retrospective. What was hypothesized and it is within this cow's milk allergy population that children with cow's milk allergy have a predisposition to atopy, have a delayed maturation of the Th1 response during childhood, which puts them at increased risk for infections in the first year of life. You will see within this paper, they highlight all of the data that have been shown in the past on increased risk of respiratory infection, which includes number of siblings, C-section, nursery attendance, older maternal age, socioeconomic status, mode of feeding, reduced gestational age. And you can already see at this, looking at these number of factors, that many of them overlap with the factors that have been highlighted to influence the microbiome. Which begs the question, could dysbiosis contribute towards infection? And most of you know the hygiene hypothesis around this, but also the cesarean section, the antibiotic therapy, the breastfeeding versus formula feeding, the number of siblings, and the very well-known imbalance between Th1 and Th2 with a leaning towards Th2 response here. And so I think it's really important for us to consider all of this, which I think has been well highlighted within the gut microbiota and immune response and food allergy. Many of you have seen lectures like this, and I don't think one slide does this complex topic justice. But to summarize for you, that within the first 3 years of life, you have the developmental phase of the microbiota within 3 to 14 months, then the transitional phase between months 15 to 30, and then you have a stable phase. So those first 3 years of life are critical. We also know through many publications that in allergic infants, there's a presence of altered gut microbiota or dysbiosis. We know that bifidobacteria are the first colonizers of a healthy infant gut, but that in children with food allergy, in particular with IgE-mediated allergy, they typically have lower levels of bifidobacteria. And we also know that the microbiota diversity is lower in children with cow's milk allergy. More recently, data has indicated infants with a non-IgE mediated allergy have dysbiosis driven by Bacteroides and Alstipes. There's a wonderful study also to show that the composition of gut microbiota at age 3 to 6 months was associated with milk allergy by age of 8 years, with enrichment of Clostridia and the phylum Firmicutes. If we look at this in more detail, there are around 8 cross-sectional studies published on the gut microbiota with food allergy, primarily cow's milk allergy. I'm only going to highlight 2 out of these studies. So a study by Thompson has looked at children which they recruited at the diagnosis, and I want to just say these were 46 children with cow's milk allergy, 46 at control. They were formula fed, both of the groups, and the group with cow's milk allergy had no pre or probiotics added, which I think for a microbiome study is really important. From the start, you could see differences, and in particular, the cow's milk allergy, so you can see the diversity is very different, but also the anaerobic level of a microbiome was from the start higher, and in particular, you could see in the group with cow's milk allergy, they had higher lactobacilli and lower bifidobacteria, which I have highlighted before. And the study by Kurosh on IgE-mediated allergies, really highlighted the fact that specific microbiomes and differences between the Clostridia class and Firmicutes as well. Now, this wonderful paper on the immune system, in particular respiratory in the microbiota, highlights and postulates different areas where the microbiota can be modified and be protective. And this includes the different layers from the intestinal lumen, the mucus layer, the epithelial layer, and the propria as well. This includes the competition for adhesion sites and for nutrients, the production of bacterial metabolites for short-chain fatty acids. And all of you know that short-chain fatty acids changes the pH, so creates a more acidic environment with less pathogenic bacteria, the production of antimicrobial substances such as the antimicrobial peptides, and of course the supporting the epithelial mucosal barrier here as well. Now, how can we as clinicians help our patients? The first source of how we can help is supporting breastfeeding. We do know that breastfed babies have a more dominant bifidobacteria microbiome, and this is further aided by the human milk oligosaccharides, which have a potent impact on the defense system and also have an impact on the immune system as well. Human milk, of course, contains also genera of bacteria, including lactobacilli and bifidobacteria, but we also have this very unique enteromammary pathway where the bacteria from the maternal gut through the mesenteric lymph node gets transferred, and the mammary gland and children that breastfed babies also receive probiotics that way, and then, of course, around the areola. Now, we do know that breastfeeding prevents infection. This is a recent systematic review, just highlighting what we already know, that children who are breastfed and have less gastrointestinal infections, fever, gastroenteritis. Now, what if breast milk is not available? So data has really evolved and has really looked at not only prebiotics and probiotics, but more recently, symbiotics. And this is the well-known ASSIGN study, which Adam Fox is the first author of. In short, this is a study where they've used an amino acid feed, which was enriched with symbiotics, which short and long-chain fructooligosaccharides and bifidae breve. And they have compared that to an amino acid feed, and then the grey stripe population is your control reference healthy breastfed population. You can see that within the first 8 weeks, the control feed is lower in terms of the bifidobacterial population, and the test feed with the symbiotics is already pushed within the domain of healthy breastfed infant feeds. And here, in terms of the pathogenic bacteria, the Eubacterium rectale and the Clostridium, you can see within the first 8 weeks, it's already pushed within the lower domain, which you see with breastfed infants. And this is maintained over the first 26 weeks. What is exciting from this data, with analysis, they found also fewer infections and use of antibacterial, for example, amoxicillin, the fewer ear infections, fewer infections requiring hospitalization. We've seen also this effect on the concomitant medication use, as I've already highlighted, the lesser use of amoxicillin, but also dermatologicals, so for creams that are used. And I think this is an extremely exciting area that possibly through manipulating the microbiota, these concomitant burden of infections can be reduced. So I want to conclude that the recent data we have published using a thin database where we almost looked at 3,500 children in each group indicates that children with cow's milk allergy have a higher respiratory, skin and gastrointestinal infection. And I'm sure many of you listening to this presentation will have found very similar experience in your patients. Now, this association with increased infections has been published by other studies, but as I highlighted, we need more data. Many of the studies are retrospective, but it's been hypothesized by this wonderful publication by Fiocchi that dysbiosis may be involved. And we know that dysbiosis is reported in cow's milk allergy. So what can we as clinicians do? Support breastfeeding, because breast milk is the best source of nutrition and the best source also for pre and probiotics. But that if breast milk is not available, it's an exciting prospect that the manipulation of the gut microbiota through infant formula may offer a really promising option to support the immune system. I hope you found this presentation really interesting, and I'm looking forward to your questions. Thank you.
Another really interesting presentation. Thanks to Dr. Roseanne Meyer. I certainly found it interesting to hear about the relationship of increased infection and the diagnosis of allergic disease. It's certainly something I, as a parent, saw very much in the early few years of my own son's development. So really interested now in what the panel has to say about some of the studies that Roseanne put forward. And we do have a couple of questions that have come through. So Pete, did you want to say what the highlight of that presentation was for you?
Well, a lot of highlights there. Ros is a very well-known speaker and expert in this area. I think raising the fact that the whole microbiome shapes our innate immune system and we sort of the frontline barriers is critical, and the first-in bacteria that seems to be the best dressed. Supporting them seems to continue that. And if there's danger signals actually probably happening at the gut epithelium, that may have flow-on effects to other organs as well. It may shape our responses of foods that should be innocent and not evoke any inflammatory responses, possibly dangerous.
Yeah. One of the questions that's come through is about how does an infant's gut microbiome affect risk of development of allergy, immunity, and overall health? Libby, maybe if you can respond to that one. And I guess, how do people explain this simply to parents of children with allergic disease? I think we're having trouble hearing you, Libby.
Yeah.
Okay, that's better, I think.
Okay, now I've unmuted myself. So I usually try to explain it to parents that we can be a bit too clean, and that we will often need to, expose kids to dirt on the floor and dirt on their animals and so forth. I say to people, the immune system is basically set up to fight germs. And if you're not giving the body adequate germs to fight, it kind of looks for something else to fight with. So, food substances or whatever, so that basically what they need to know is that we've got to keep the gut microbiome as close to normal as we can, which means getting some germs in there in order to protect the kids' ongoing health.
Yeah, so it can be, well, it is deeper than that. I think I remember, as a parent, thinking it was just about my environment, but it's about my internal environment just as much as external environment is what we're understanding now. And there's certainly still much more research to be done. But 30 years ago, we talked about the hygiene hypothesis, and certainly my understanding was about everything in my environment and not within me as a mother breastfeeding my child or my child's microbiota. But we've certainly learnt a lot more since then. Kathy, did you want to share how you might explain this to a parent that asks you about it?
Well, what I usually say is, many of the patients I see come to me, the mother is on a restricted diet because the child has some reactions. They'll exclude many foods from their diet, and will be very concerned and anxious about introducing lots of family foods to their baby. So one thing I tend to say is using a good range of different foods, a good variety of foods for all family members, and teaching the child to eat what the rest of the family are eating. And so that's probably what I see as my role, or one of the things that I usually say about developing a good microbiome. And continuance of breastfeeding. Sometimes we have to reduce the frequency of breastfeeding so that babies will actually increase when babies are fed all night, then they often won't want to feed during the day. So I don't want to be coming across saying no breastfeeding, but I just, appropriate amounts of breastfeeding during the weaning phase is recommended if both mother and baby are in agreement. And
what about
I often get
supplementation?
asked. Yeah, so I
Sorry,
often get
Kathy.
asked, should I be taking, that's right, should I take a probiotic? And, I say to families, well, yes, it does look like probiotics and prebiotics and symbiotics are most likely beneficial, but we don't have exact evidence about which one in what amounts and for which condition. So if the children are already on probiotics and the families are happy to be spending the money that they're spending on them, I say there's no harm in not having them, but it's not so evidence-based that I can say definitely it's going to improve. So it sounds like a wishy-washy answer, but we have to practice evidence-based medicine.
Yes.
And I tend to say that having a wide variety of different fibres and foods and grains is a much better thing to do, and that's something that everyone can do in the long term, and feeding family foods and eating together.
Really important. There's a question
In
here
addition to the
sorry.
That's okay.
Sorry, Kathy.
Continue.
A question here for Pete. Of the children who have gastrointestinal distress caused by cow's milk at age 5 years, what percentage have cow's milk allergy and what percentage have lactose intolerance?
Okay.
Are you aware?
Look, we see a lot of children grow out of their cow's milk allergy by 5, but we certainly see the ones who often aren't are often polysensitized, and they have other allergies going on as well. So it's not just as simple as pure cow's milk allergy. I'd say far more children would have lactose intolerance. We have had a little bit of chatter on the background there with lactose being a probiotic. And so we'd see more children with relatively more disaccharidase intolerance, so the inability to split sugars. Now, lactose is glucose and galactose, and we see lactose intolerance from an overload of that enzyme system. We see it, and if that goes through, it breaks down to little acids, acetic acid, propionic, butyric acid, which and the bacteria love them and thrive. So there's potential good benefits of lactose intolerance. If people do have significant lactose intolerance, that can be from non-IgE mediated cow's milk inflammation and flattening of the villi. But we also see it with celiac disease or other causes. So just by saying somebody's got lactose intolerance, they could have that hereditary lack of the lactase enzyme, which particularly gets impacted after they've had their first bout of gastro in the first 1 or 2 years of life. But if it's persisting and causing that watery explosive diarrhea, you probably need to make sure and particularly if it affects growth. I don't mind them having occasional loose bowel actions, but if it's affecting growth or causing pain, discomfort, it needs assessing.
Yeah, that's right. Thanks, Pete. Another question here on what effect does omeprazole have on the microbiota? Who'd like to put their hand up for that one?
It significantly alters it and may be more Clostridia friendly. It will. Our stomach is meant to. Our lactobacillus loves lactobacillus acidophilus means I love acid. So if it does not have that habit, it impairs. What was it? These drugs are licensed. The registration use is for a period of 8. If you look at the FDA registration, it is 8 weeks of use in 1 to 11-year-olds. It has no safety data under 1. The Australian data, the US FDA says maximum 1 year, but it says 8 weeks of use for adults, adolescents, and children, not long-term use. There's higher rate. We cannot make a child we cannot make an animal model of food allergy allergic unless we turn off the stomach acid. It affects gut microbiome. It increases enterochromaffin cells in the stomach, atrophic gastritis, I think we get jumped to kids with reflux disease way too easily with this.
Yeah, thanks, Pete. And Libby, you had something to say on this too?
Yeah, I agree with Pete's last comment. The way my patients come to me, usually, most of them have already tried omeprazole. Interesting that the human stomach doesn't actually make a whole lot of acid until the kid's at least 2 months old. And you find, the grumpy babies of 2 weeks, GPs, the first thing they do is reach for the prescription pad and give the person omeprazole. And I don't know whether that's the GP feeling desperate or the mother being demanding. But, I'm really worried that, first thing is everybody tosses medicine at them. Second thing I'd say is that lactose intolerance, primary sense, is incredibly rare. And I think, a lot of people label everything that can't tolerate dairy as lactose intolerance, which drives me crazy because I've seen far too many of my IgE-mediated cow's milk allergic patients having anaphylactic reactions because somebody assumed that a lactose-free something or other was actually safe because it's all the same, isn't it? So one of my people that taught me medicine used to say sloppy terminology equals sloppy treatment. And I have to say that I think doctors and other health professionals need to actually understand that lactose intolerance is not everything related to dairy problems, and that if we actually label things appropriately, we can help patients to manage themselves better.
Yes, thanks, Libby. I think, this whole issue of lactose intolerance really does confuse cow's milk allergy. We have a lot of reports of children being fed lactose-free products in childcare facilities, and it is really difficult to get people to understand. I think our message of lactose-free is not suitable for anybody with a cow's milk allergy because it's generally the protein that causes the problem is a message that we need to be singing from the treetops all of us need to, I think, make a concerted effort, because even amongst health professionals, that's not well understood. So thank you for making that point. Okay, so we'll move forward now to the next recording of a expert. The expert, Dr. Rebecca Stratton, who is an honorary research fellow at the University of Southampton, and she is the medical director of Nutricia. Welcome Rebecca's presentation on can we improve the management of cow's milk allergy through modulating the gut microbiota, a great follow-on from Dr. Roseanne Meyer's presentation.
And thank you to the organisers for inviting me to speak today. Improving both the detection and management of cow's milk allergy is something I have a huge passion for, not just because I'm a dietitian or a researcher, but also because I'm mother of a child who had a very severe form of allergy to cow's milk protein. And so today what we're going to be looking at is how potentially modulating the gut microbiota with symbiotics could improve the management and the outcomes of infants and children with cow's milk allergy. So you've already heard so beautifully from Kate already about the new evidence that we've been working in collaboration with that shows the potential longer-term clinical and healthcare burden of cow's milk allergy. With a very large retrospective matched cohort study, we have shown that infants with cow's milk allergy have more gastrointestinal, skin and respiratory symptoms and a higher probability of those symptoms persisting with time. More gastrointestinal, skin, respiratory and ear infections, greater medication prescriptions and greater healthcare use. And what are the reasons for this? And what are the implications for the nutritional management where breastfeeding is not possible? Of course, acknowledging that breastfeeding remains the best option for infants with cow's milk allergy. And of course, one hypothesis is that this greater clinical burden could be due to the effects of gut dysbiosis that we know can be prevalent in infants with cow's milk allergy, and the impact that that has on the inflammatory and immune response and system development. So with that gut dysbiosis, we can hypothesize that if we can modulate the gut microbiome through nutritional intervention, including symbiotics, could we improve the outcome of infants and children with cow's milk allergy? And this is a topic of research that we have been working on this year, and I'm going to show you two of those areas of research. So firstly, I'm quite passionate about undertaking systematic reviews and meta-analyses. This systematic review and meta-analysis has looked at randomised controlled trials that have compared the use of a hypoallergenic formula with symbiotics with a hypoallergenic formula without symbiotics. In our inclusion criteria, we're looking at both extensively hydrolyzed formulas and amino acid formulas in studies. However, there were none at the time of the study of extensively hydrolyzed formulas. All of the searches were done in November 2020 according to PRISMA guidelines, and you can find all of the methodology in the full publication, which you can see here on the screen. We included studies in infants and children less than 3 years of age with IgE or non-IgE mediated cow's milk allergy. So what did we find? We found 7 publications of 4 randomised controlled trials in infants with both IgE and non-IgE mediated cow's milk allergy, with a total population of 410 infants. All of the randomised controlled trials compared an amino acid formula with both pre and probiotics, so symbiotics, a specific mix, as you can see here. This was given for a mean duration of 7 months, and in all cases, the randomised controlled trial compared this with infants receiving an amino acid formula without symbiotics. The majority of publications were at low risk of bias, and again, more information can be seen in the publication. So what did we find? Well, when we put together the data that could be combined on infections from 3 randomised controlled trials, you can see here from our meta-analysis plot that infants randomised to receive a cow's milk allergy formulation with symbiotics had significantly fewer infections. And in one study, they looked specifically at ear infections. It should be of note that the infection data was in the adverse event data. It was not a primary outcome. The infants had either IgE or non-IgE mediated cow's milk allergy, and the intervention periods ranged from 8 weeks through to 12 months. In the systematic review, we also looked at hospital admission data. And we found this in one of the randomised controlled trials. And you can see here the summary of the results on the right-hand side of the slide. Intervention with 12 months with amino acid formula containing symbiotics led to significantly fewer hospital admissions than in those in the control group receiving an amino acid formula. These were hospital admissions due to gastrointestinal infections. Then what we did was to do a cost analysis based on the data in this one randomised controlled trial and based on the combination of randomised controlled trials from the meta-analysis. And using reference costs from our healthcare system here in the UK, and looking at the cost of the formulation and the treatment of the symptoms, etc., over that period of time, we could estimate potential cost savings of between £164 and £338. And last but not least, we were also really interested in medication usage. It wasn't possible to combine the data into a meta-analysis. However, we were able to look at common findings on medication use. And you can see here in the figure that when you looked at the two randomised controlled trials that looked at antibiotic use, we saw a marked reduction in antibiotic use in the infants who were randomised to receive an amino acid formula with symbiotics compared to those who were randomised to just an amino acid formula. Individual randomised controlled trials also found significant reductions in the use of functional gastrointestinal medications and significant reductions in the use of emollients, protectives, and dermatological medications. So then we want to understand, well, actually, what is the reason for these differences in outcome? And we don't fully know. We looked at 3 different aspects. We looked at were the allergic symptoms different between the two groups? And actually in the systematic review, looking at 3 papers that looked at allergic symptoms, the 2 formulations were equally effective at the symptom resolution in the short term during the period of the follow-up. We also looked at the data on growth. And the systematic review, again looking at 3 papers, found that the hypoallergenic formula with symbiotics was equally effective as one without symbiotics at supporting growth in line with expected ranges. Again, looking at the measures that were in the research papers that we reviewed, weight, length, head circumference, over the period of the studies, which was 8 and 16 weeks. But we were particularly interested in the gut microbiota and markers of the gut microbiota. A meta-analysis of 2 randomised controls and 3 papers found that a hypoallergenic formula with symbiotics compared to one without led to significantly greater fecal bifidobacterium species and significantly lower fecal eubacterium and clostridium species. And in one trial that looked at bacterial diversity, it found that those who were randomised to the amino acid formulation with symbiotics had significantly lower bacterial diversity and a bacterial profile that was closer to the healthy breastfed reference group. So we've looked at systematic review that combines the randomised controlled trials together into a meta-analysis. But we're also quite interested in what happens in practice. And this is a different form of methodology, a different form of research that we have also undertaken this year. What happens in real world? And in the UK, we're very blessed to have large GP databases to have access to undertake some good research questions. So we undertook a retrospective matched cohort study using data from FIN, the Health Improvement Network. And within this, we looked at 148 infants with cow's milk allergy. And we looked at a cohort who were prescribed an amino acid formula with symbiotics. Again, you can see the specifics there, the pre and probiotic used, compared to a group that were matched, receiving an amino acid formula with no symbiotics. You can see the details of the publication there on the slide. We looked at a number of different outcomes, similar to we've looked at in the systematic review. So symptoms, infections, medication prescriptions, and healthcare contacts measured from diagnosis during the period of time that they were followed up. So what did we find? What you can see here is a summary of the data looking at clinical and healthcare outcome rates per person year in infants with cow's milk allergy. And what you can see very nicely is that in those in the cohort receiving the amino acid formula with symbiotics, they had significantly fewer symptoms, significantly fewer infections, significantly fewer medication prescriptions. We also looked at healthcare contacts, so that include dietetic contacts and hospital admissions. Those were lower, but they were not statistically significant. And these were measured over the period from diagnosis over the observation period. We also undertook some statistical modelling, and I have our very excellent statistician to thank for this. We undertook a Cox proportional hazards regression model to really look at the differences between the amino acid formula group and the amino acid formula with symbiotic group. What you can see here on the left is that compared to those receiving the amino acid formula, the infants in the cohort that were fed an amino acid formula with symbiotics had a significantly higher probability of achieving asymptomatic management without a hypoallergenic formula. So this was a composite outcome of no symptoms and no hypoallergenic formula over a 3-month period. And if you look on the right-hand side here, you can look at the probability curves of those two groups, looking at symptoms and hypoallergenic formula use persistence. And what you can see here is that those probability curves are significantly different. If you look at the red, that's for the amino acid formula. And if you look at the blue, that's for the amino acid formula with symbiotic groups. You can see that they are markedly different. We also were able to estimate through modelling the median time to achieving this composite measure of asymptomatic management without use of hypoallergenic formula. And what you can see very nicely here on the slide on the right is that there was a shorter median time to achieving asymptomatic management without hypoallergenic formula in the infants given the amino acid formula with symbiotics compared to the group who did not have symbiotics. It's about a 31% difference, 1.95 years to 1.35 years. As part of this, we undertook an indicative cost analysis, looking at the costs of the use of the formula and the costs of the treatments and the healthcare use. Between those two groups, we could estimate a potential cost saving over the clinical course of symptoms of around £452 per infant. And again, we can't from this type of study attribute any causal effect or what was the reason for this difference in outcome, but it could be to do with the impact of the symbiotic formulation on the gut microbiome. So just to finish, the infant gut microbiome plays an important role in immune development and function. And gut dysbiosis in infants with cow's milk allergy may be a contributory factor to the burden of allergy. Of course, breastfeeding remains the best option for infants with cow's milk allergy, but if a formula is required, new research is showing that use of a hypoallergenic formula containing symbiotics is associated with significantly fewer infections, prescriptions, and healthcare use compared to a formula without symbiotics. I've also talked today about real-world GP data that suggests a higher probability of achieving asymptomatic management without hypoallergenic formula and a shorter median time to achieving the asymptomatic management without use of a hypoallergenic formula with the use of a symbiotic containing amino acid formula compared to one without symbiotics. Of course, the outcomes observed in this research may be related to the effect of the symbiotic on the gut microbiome, bringing it closer to that observed in studies of healthy breastfed infants. But of course, it's very clear that more research is still required to ascertain the longer-term impact of modulating the infant gut microbiome for better outcomes in the management of infants and children with cow's milk allergy. Thank you very much.
an excellent presentation by Dr. Rebecca Stratton. Really interesting to hear about the infant gut microbiome and the impact that it has on development of function. And of course, there is always more of a need for more research. It's wonderful that we have so many people research looking into cow's milk allergy, the gut microbiome, and the many other factors that impact development of allergic disease. So we're moving now into our last panel discussion, and we only have one question, time for one question. As we then move into our last pre-recorded session by Dr. Vicky McWilliam. The question that I'd like to put forward to our experts is, would you suggest any supplementation for the mother or the baby to assist with the prevention or the treatment of allergy? So what is your general advice to people around supplementation for the prevention and then for ongoing treatment of allergy? And we might start with Libby.
Unmuting. My general philosophy is that probiotics probably wouldn't hurt, but there's not enough evidence to say that they're particularly useful. I agree with the comment made before about probiotics. We don't know which ones are good for what, for how long and how often. But I think, in terms of vitamin supplementation, one of the interesting things that I see in my practice is I see a lot of families that have, vegetarian diets or low-fat diets or whatever, and those for various, cultural reasons. A lot of vitamin D deficiency during pregnancy for the mothers, obviously. The mothers may or may not be supplemented, but then the baby comes out with an exactly matching vitamin D level to the mother, and then everybody forgets to supplement the baby. And we know quite clearly that low vitamin D in babies does predispose people to develop more food allergies. So, I'm very keen on making sure that people get enough vitamin D. Most people who breastfeed will personally take a breastfeeding multivitamin, so probably, the mothers are up to scratch. But it's the babies that I worry about that nobody particularly thinks about what do they need.
Thanks, Libby. Pete, what advice do you generally give people?
I'm not actually asked after the horse has bolted usually, but I think we're really taught to recognise disease and treat it. Very little on the evidence of, and in fact, we know risk factors, as Libby's pointed out, and associations, but not the studies that have intervened. So we know that vitamin D deficiency is a factor, and we see this in children that are born in spring having high rates of food allergy because their mums have just gone through winter. We also, there's studies that implicate low magnesium, low zinc, low selenium, but they have not been put into studies in prevention. So it's hard to say do this. But yes, we haven't had a good volcano in Australia for 20 million years, and a certain amount of our population have low magnesium and low levels, or on things like PPIs at lower magnesium levels. We're on. So I think the best information that we could get based on the evidence is eat a broad diet. We know that leafy greens increase the bacteria. So don't have the processed food that removes all the fibre. Don't feed kids fruit juices. Don't have that high sugar load that we know creates inflammation in the body. So eat healthy. Our vitamin D levels that we have are historically based for determination of rickets. They're not healthy levels. They're disease levels. If somebody has low vitamin D, they're not healthy range. Their healthy range should be 50% to 100% higher than our disease levels, and we're starting to see warnings on the pathology report saying under 70 still increases risk of osteoporosis. It's still actually up to 100, but it's starting to appear on report that it's in our normal range, but it's being flagged as abnormal by the path labs. So eat well. Good headspace is important, as I've mentioned about the gut inflammation. Good sleep, we know that creates more histamine release, lowers the threshold for allergen reduction. So getting our whole body balanced, again, these type of things we have got so much room to improve on, but are difficult to study.
Yeah, so thanks for that, Pete. So it really is, Kathy, in line with what you said when we first started this. It really is about going back to basics and trying to, looking at all aspects of well-being and progressing on all those different theories, I guess. Some are more than theories now, though, aren't they? We know that vitamin D does have a real impact. We know that the antacids reduce. We know that maybe processed foods aren't the best for people because of sugar content and so forth. So I'll. Would you like to have a closing comment on that aspect?
Me? Yeah.
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 Okay, sorry, yes.
Once again, that's what I always talk about with families. I also, back on the comment that Pete mentioned about adequate sleep. Often with babies, of course,
Will do.
Many families are sleep deprived, and so I often recommend asking for help. Having someone to look after the baby or take the baby away for a little bit so the mum can sleep in the afternoon. I mean, that's a bit non-dietary, but getting back to the dietary and the vitamins and things like that, I usually, because they're little babies that I'm seeing, if we're talking about prevention, I'm usually seeing them because they already have existing allergy. So once again, the horse has already bolted. But one thing I always explore is, especially in the maternal diet, if it's a cow's milk allergy and the mother is excluding milk, I always look at what their intake of calcium is. And the question is, do they have a calcium supplement in addition to vitamin D? And most of the times I will say to the mum, did you have your vitamin D tested in pregnancy, which is what is commonly done now? And 9 times out of 10, they say, well, it was low during pregnancy. So I recommend that they take a vitamin D and calcium supplement, but then, of course, discuss long-term with their GP about vitamin D levels for the mother.
Thanks for that. I think, moving forward, we need to look at, we talk about early introduction of common allergy-causing food to help prevent food allergy, but there is a lot more that we should be doing even through pregnancy and before starting food. Pete, one last comment, and then we need to move to the next recording.
Okay, fabulous. I'll throw in two though. But the bowels making butyric acid, these bacteria with fermenting, which is really what part of what the story was about in the last lecture, do deacetylate some DNA and get mature responses. Butyrate can actually lower adhesion molecule expression, which viruses stick to. So there's actually a lovely immunological story. Most vitamin D, if you add calcium, it increases intravascular calcium. So I don't like vitamin D and calcium. I like vitamin D and K2 because K2 increases the vitamin D receptor, so it goes into the cells. And vitamin D, again, starts to consume magnesium in many of its processes. So you don't want to tank other vitamins because you're actually adding another one in, particularly when they've been deficient. So it needs an expert. And the GPs have not been trained in micronutrition.
Yeah. So look, it is complex, and there's a lot more. We know a lot more, but there is a lot more to learn and a lot more to share. So I'd like to take this opportunity now to thank our guest panelists for being part of this webinar and panel discussion. As we move into our next recording from Dr. Vicky McWilliam, who is a senior allergy dietitian at the Royal Children's Hospital, an honorary Senior Research Fellow of the University of Melbourne. Vicky is going to speak to the patient or the parent perspective of living with food allergy, and then she's going to have a chat with two parents, Liana and Cara, about their their journey of diagnosis of cow's milk allergy. So, we'll move to Dr. Vicky McWilliam now.
Okay, I'd like to welcome everyone to the session and thank two of the families that I see in my practice who are going to be joining us for a session today. I'd firstly like to introduce little Jacques, who's a 12-month-old boy who is been diagnosed with presumed multiple non-IgE mediated food allergies and an IgE mediated egg allergy. And at birth, if we go through his history, at birth he was born quite a nice size at 4.9 kilos, but he had early onset vomiting and was frequently breastfeeding, probably a maximum of 2-hourly gaps between his breastfeeds. Around 3 months of age, he developed quite a significant skin rash, and then he had both the rash and vomiting were enough of a concern that mum raised this with the health nurse. The health nurse dismissed this as really just normal rashing and normal vomiting that you would see in a normal baby. But by 4 months of age, the vomiting was really persisting and he was very irritable. He had very poor sleep. He was probably only doing 6 to 8 hours sleep in 24-hour period. Lots of back arching and very irritable. And his skin rash really worsened. And the GP at that stage then diagnosed him with eczema and they'd commenced on some topical steroids. So this journey for this family was all during the COVID pandemic. So a lot of access to health services was quite difficult for families at this time. So at 5 months of age, the family were then reviewed by the GP. And at this stage, the GP then referred on to a tertiary level paediatric hospital because the vomiting was really quite significant. The family were quite concerned. His irritability and the back arching were really quite significant and the family were quite worried. And at this stage, the GP made contact with the paediatric tertiary hospital, so the Children's Hospital here in Melbourne, and they really suggested that a surgical review be done. So at that stage, he had an overnight admission and ruled out intussusception and other surgical complications that might be driving his symptoms. So at 5 months of age, this is when his mum, Cara, started on a maternal elimination diet of cow's milk protein, and she was referred to a specialty allergy service. So within a week of taking cow's milk out of her diet, there was a dramatic improvement in his symptoms, but he still had ongoing mucus and abdominal pain. And there was a long wait for an allergy appointment. So mum had been told that maybe up to 6 months wait before they could get in to see an allergist. So mum self-managed with food diaries. She identified soy, rye, rice and oat as additional food triggers. So all of these things she took out of her maternal diet. And she was managing this by herself with really little help from an allergist, no dietitian, and they'd seen a GP locally at that stage. Between 5 and 6 months of age, they tried egg as part of his solids, and he had an immediate reaction with vomiting and sneezing. And this actually escalated things, and they were able to then get a referral to a paediatric allergist. He also had some delayed vomiting reactions with rice and oat, which were probably pretty typical of an FPIES reaction. So by 7 months of age, he's finally got in to see a paediatric allergist, and he had skin prick testing done with an egg white skin prick test of 4 millimetres and a milk and soy skin prick testing that was negative. In Australia, we tend to use skin prick testing as our first line of allergy diagnostics rather than specific IgEs. So skin prick testing was what was done for Jacques at this stage. He was diagnosed here with a non-IgE mediated rice, rye, oat and soy allergies and an IgE mediated egg allergy. He was placed on amino acid based formula on prescription from the allergist, and he received a referral to a dietitian, which was me at that stage. At 8 months of age, he was on a combination of breastfeeds with maternal diet exclusions, and the amino acid formula was established, so he was having a combination of both. But they ran into some issues with access to the amino acid-based formula. We had a recall of the product in Australia, and alternative brands were really difficult to access because of COVID restrictions, and access of products in Australia got really quite challenging over this time. At 10 months of age, he had a review with his allergist. And at 12 months of age, which is actually today, is that right, Cara? It's his birthday today? Yeah. I noticed that on the notes when I was putting these together. So at 12 months of age, the plan has been that he would have a baked egg oral food challenge to see whether we could incorporate baked forms of egg into his diet for his IgE-mediated food allergy. The plan was to commence reintroduction of cow's milk back into his diet through a milk ladder, but ongoing avoidance of rice and oat was discussed really because of the suspicion that these may be FPIE's food reactions that he was having to those two food proteins. So I'm going to introduce our second family, and then we're going to have a chat with Cara, and we can go through some of the experiences that she had regarding diagnosis and her journey with food allergies. So the second family that I'd like to introduce you to is Mia. She's a 10-month-old baby with presumed non-IgE-mediated cow's milk and soy allergies as well. Her history and presentation has been at birth. She was breastfed exclusively. Again, quite a nice-sized baby. She was on the 97th centile for weight and length at birth. But really quite early on, she had extreme nappy rash. So within 10 days, she had quite open, large blisters on her bottom, so quite a nasty nappy rash at that point. Again, this family have been experiencing dealing with allergy over the COVID pandemic. So in June 2021, they live regionally, so she had limited access to GPs and health professionals. It was all telehealth appointments at this stage. So Leanna, the mum, contacted a health professional friend, and they recommended trialling maternal diet elimination of cow's milk at this stage, which showed an immediate improvement when cow's milk was removed from the maternal diet. The rash healed almost immediately, but mum was actually using soy milk as her milk replacement at this stage in the diet. At 6 weeks of age, we have a general paediatric assessment that gets done of all infants. So living regionally, this 6-week appointment was done with the GP for Mia. And at this point, mum re-challenged cow's milk back into her maternal diet to see whether the symptoms reappeared, which is part of the guidelines for the diagnosis of non-IgE-mediated cow's milk allergy at present. The rash reappeared within 10 days with inconsistent and smaller amounts of cow's milk being reintroduced, and bowel actions were occurring every 3 days, but Mia was experiencing no growth issues at this point. At 4 months of age, at another GP referral, the cow's milk reintroduction was retrialled. So around day 6 or 7, there was increased bowel actions and mucus and a fever this time, and blood appearing in the stool with a reintroduction attempt with cow's milk. At this point, the GP was still the family's main point of contact. So at this point, the GP recommended to cease breastfeeding and commence on a rice-based formula, which the family were able to access without a script and buy that over the counter in Australia. And when they transferred Mia over to the rice-based formula, the blood and the mucus cleared. At this point, there was a referral. At 7 months of age, there was a referral to an allergist. And it took until 8 months of age for the family to be able to get in and see an allergist. And at that point, they were also referred to an allergy dietitian. So by this stage, Mia had ceased breastfeeding, and she was on a rice-based formula from 4 months until seeing an allergist for the first time at 8 months of age. So at 10 months of age, she remains on a rice-based formula. She's progressing really well through solids and the intro of milk and she's progressing really well through introduction of milk and soy-free solids, and she's experiencing no issues with growth. And there's a review scheduled at 12 months of age with the plan to reintroduce milk and soy, and the reintroduction of milk would be through a milk ladder. So that's just a bit of background for both the babies that we're going to meet their mums and have a bit of a discussion about how things have progressed for them. All right, so Cara and Leanna, I've just got like some questions to kind of hone in on some of the points about your experience. So if you could, if you're happy to share some of the experiences around some of the challenges that you had around diagnosis. So I think maybe we'll start with Leanna. What have you found kind of the most challenging aspects in the early stages of the diagnosis with your journey with Mia?
Access to GPs. I mean, because we're regional, we don't have a lot of access, and most of our GPs, especially during COVID, were booked out sort of minimum 8 days in advance. So when you really needed to see someone straight away, it was really difficult. Mia's specific GP is quite sought after. So sometimes her appointments are sort of 5 weeks in advance. So you really sort of need a unicorn appointment to be able to have the same sort of consistency with GPs. So I think before she was 3 months old, I think we maybe seen 6 or 7 GPs at the one practice, just because we didn't have any space to be able to get into anyone. That and stopping breastfeeding. I really didn't like stopping breastfeeding. I really wanted to continue. But that was sort of what was suggested to me at the time that would be more beneficial to her. So it turns out that it was more likely just the soy in my diet that was affecting her rather than the cow's milk, because I had ceased it by the time the blood had become in her stool. So that was a little bit disheartening, but also, I guess, good that she started to get better.
Yeah. So access to timely information and probably best practice recommendations being and to assist you with breastfeeding. Yeah. Cara, what about for you? Your journey took a little bit longer. So to get a diagnosis and to really get on track, it took several months for you guys. So what were some of the things that you found tricky?
I think trying to communicate that you think there's something wrong, and everyone dismisses you because you're first-time mum for me. And so they just think that I'm complaining about a baby who's not sleeping, or perhaps there's a baby who's doing a few more spit-ups. And so I had a lot of, not to worry, it's just likely that the esophageal sphincter hasn't fully developed. It will take up to 12 months, but it will go away. Don't worry about it. And then every time you raise it, you get the same answer again and again. And I was just thinking, parenting's way too hard if this is parenting. But then when you get through to the next doctor, you ask the same questions. Could it be an allergy? And again, it's just dismissed as, no, not to worry about it. So that bit I found really frustrating. And then even when we could progress it through to the hospital level, again, you'd ask, could it be an allergy? And the response is, oh, maybe it could be, but super unlikely that it's going to be. And they get a diagnosis of gastroenteritis, or and that I should just go home and there's nothing I can do for it. And I've got a very unhappy, crying, upset baby who's doing spit-ups. By the time we hit to 5 months, who's doing little vomits every 10 minutes. So it's just, you can't have a baby that's vomiting that much. But because he was gaining good weight, everyone would just say, no, technically your baby is thriving. If he's up there in the 96th percentile, then he's thriving, and go home, don't worry about it.
Yeah. And I think you had the same experience, Leanna, that Mia was growing quite well. So that often has things dismissed for a little bit longer when your baby's thriving and doing really well.
Just really clouds their judgment, I think.
Yeah. So the alarm bells always ring when we're dealing with babies that aren't growing so well, a lot more urgently than at other times. So going to the positive as a follow-up, Leanna, what have you found to be the most useful and the most helpful with your journey with Mia?
The fact that we could get in so quickly to an allergist, like that was abnormal. Most mums don't have that experience. And after I got to speak to you, it was really, really helpful. I was really concerned with the amount of solid foods that Mia was actually able to have, because she was reacting to almost everything at that point. But since then, I've sort of had a steadier path. It's been a much nicer experience.
Yeah. So once you got to the right place and you were getting the right specialty advice, it really helped. Yeah. And I guess what was it specifically about a dietitian that helps with this as well? Like, not everybody gets to have access to a dietitian as well. What was about that helped?
It was just more so because Mia she was about 7-8 months old, and we'd only been able to introduce sort of 3 or 4 things because we'd had to restart our solids introduction. So I was starting to question every food that I was introducing, and just having that professional backup to say, you've got these 5 things, they're from these 5 food groups. You know, she will be okay if she only consumes these 5 things because she's getting enough from each food group, just to be able to sort of progress yourself through, I guess, mentally. Mentally, it's really hard.
Yeah. And what about you, Cara? What were some of the things that were helpful or positive things for you through your journey?
I think once we actually had recognition of the fact that, yes, it is an allergy, it's sort of a weight off your shoulders because you know that you're not crazy would be a good start. And after we figured out most of the allergies, he was a completely different baby. So I had a happy, smiling baby who would sleep for longer, and I had to relearn my baby. But apart from that, it was really a massive change in our lives. And having access to an allergist and a dietitian, even if it's just a reassurance to say, yes, you're doing the right thing, you're on the right track, because even once I got the diagnosis, being able to know, similar to Leanne, was if I am giving the right food groups and am I covering all the bases. So I think just finally getting that diagnosis and getting in to see people was a big turning point for us.
For you guys. And I guess I'll stay with you, Cara, then. So for your journey, what have you found? How could you describe how this has impacted on you as a family? What sorts of challenges have you had?
Well, I think as soon as your baby's not sleeping, you're not sleeping, and then nobody is doing well in the household. And so I think that sort of goes over to then my partner, and he's not sleeping and he's got to be back at work, and everything just sort of gets turned upside down. And once we started getting the improvement, yes, he was a new baby, but we felt like new people as well because we could actually start getting sleep, and then there's flow-on effects to all of that. So from that perspective, it was great.
Sleep. Yeah. I think a lot of families would echo that the sleep disturbance and the irritability that goes with non-IgE mediated cow's milk allergy is probably the most torturous symptom for families to have to endure. So that's really hard. What about you, Leanna? What has been the things that have impacted on you as a family with Mia's journey?
Definitely the sleep. The sleep thing is a big thing, but also stopping breastfeeding once again was really quite complex. I had quite a decent supply, so the actual process of weaning was quite difficult on myself. But on top of that, the other side, we've had formula issues as well. So we've been trying to sort of go and get different types of formula, and they've all been on sort of low supply, especially in Shep. We're struggling at the moment because there's none of her formula around. There's none of the alternatives around because everyone on her formula is flocking to them. So today, especially, we've been pulling our hair out trying to find something to feed her tonight. So that...
Yeah, so that's obviously really stressful. So what do you do to source help in those circumstances? So if you're struggling with running out of a particular formula, what's your pathways for trying to deal with that?
We call as many pharmacies as we can. We have quite a good group of mums in Shepparton. We have a Facebook group, so more often than not, people are willing to reach out and help if they can. So we pose questions and things on there if anyone has any unopened things. But this has been going on for a few weeks now, so the well's kind of dry. I had your email, so I emailed you today as well, which was extremely helpful. But other than that, I have no idea where to go. So that's probably a challenging point as well. I wouldn't have known what to do. Today I would have just fed her food and hoped for the best.
Yeah, it's really stressful. And I think I could probably echo what social media groups have been able to achieve over COVID as well. Lots of families have had little call-outs for emergencies around formula supply and stuff, and other families have been able to help out. So thanks, Leanna and Cara, for sharing your experiences and what you've gone through. It's been really nice to get a perspective from parents in a symposium like this, where health professionals can hear directly through families what their experiences are. And just in summary, I'd like to emphasise a few points that we've been able to discuss in this session. Really that early awareness and acknowledgement of the signs and symptoms, particularly of non-IgE-mediated food allergies at that primary care level. So health nurses that may be visiting families that have got young babies, and the general practitioners, where families will go first often when they've got concerns about food allergy, that it's really important that they have a good understanding of some of those broad symptoms that can present as non-IgE mediated food allergy, and support families through working through getting a diagnosis, because this is a very stressful time for families, particularly with the symptoms. If sleep disturbance is one of them, it can be a torturous time for families. I think it's really important also to have some clear guidance for families of the symptoms which are red flags for food reintroductions. I think one of the areas that's quite challenging for families is knowing what symptoms to push through and what symptoms are deal breakers where you need to pull the foods back out. I find as a dietitian that can be quite challenging. Mild mucus and mild facial rashing, we will often just advise families to push through those milder symptoms, but if they're turning into urticaria or vomiting or angioedema, or the symptoms become really persistent from a GI point of view, that would be the time we would pull foods out. So support around what symptoms are red flags to stop foods, and what symptoms we would tend to push through, can help families with expanding the diet out and give them a bit more guidance. I think Leanna and Cara have emphasised really nicely the challenges that families face around the choice, the acceptability, and the ongoing supply issues of infant formula. And this can be really stressful for families. And often primary care workers don't have an innate knowledge of the differences between the different formulas. And if one is in short supply, what is an appropriate formula that we can swap over families to temporarily, or what is a safe substitution? This is often crisis information that families need help with quite quickly, and this has been really challenging, particularly in the last 2 years with COVID and the supply issues that we've had. I think there's also a lot of confusion around the milk replacement options and what is appropriate and how much. So knowing that transition from formula to milk replacements, what's the right options to choose, how much should babies be on, that 11, 12-month mark is a really good time where Leanna and Cara are approaching that age bracket now with their babies, but that's a really important time to maybe link back into a dietitian where the nutritional composition of the diet can be reviewed and what milk replacement options are being used. And the other challenging step is when and how to reintroduce the common allergens. So knowing what is safe to do as a home introduction, and knowing what needs to be done as a supervised in-hospital food challenge, knowing what age those foods can come in, and when ladders might be appropriate, and how to do that is all a challenging time for families as well. So again, that 12-month mark is often a really good time to meet back with families and give them support around the reintroduction of the allergens. And any home-based introductions, it's really good, again, to get support from a dietitian so that the families know how to incorporate those things into the diet and how much they need to be aiming for to get back in. But they're probably my main 5 summary points. And I think the rest of the symposium is going to be able to allow people to dig deeper into some of these issues and look at some of the issues around management of the different allergens. But I thank Leanna and Cara again for their time and contributing their stories and helping us to understand all of this from a family and a patient perspective. Thank you.
huge thanks to Vicky McWilliam and Cara and Liana for sharing information on real life management of cow's milk allergy. We have come a long way over the last 20 or 30 years, but we still have work to do in educating health professionals so that parents can have food allergy. Specifically, we're talking here about cow's milk allergy, but to have their children diagnosed sooner rather than later, because it really does impact not just the quality of life and the health and well-being of the child, but of the parents of the family unit. So, huge thank you as we come to a close of today's webinar and panel discussion. So I'd just like to remind all people who registered that the questions will be posted, the questions and answers will be posted, I'll start that again, that the questions will be answered, and we will share those with you with a link to the recorded webinar via digital means in the coming weeks. So it will take the experts a little while to respond to all of those questions, but thank you for participating, and I'm sorry that we didn't get to respond to all of them in the discussions. The webinar, as I said, has been recorded, and a link will be sent to those who registered. I'd like those who are online to please take the time to respond to the survey that you'll be invited to complete at the end of this webinar. It will help us to progress educational offerings moving into the future. And I think we appreciate your feedback, and we'll look at that with the development of further educational opportunities. There is more to come. Coming soon, there will be a practical interactive online workshop, a couple of workshops through 2022. One is under diagnosis versus overdiagnosis of cow's milk allergy, and how to optimise timely and accurate diagnosis. So myself and Dr. Elizabeth Pickford will be presenting that workshop, and then there will be another workshop presented by Kathy Beck and Professor Pete Smith on opportunities and concerns of using plant-based formulas in cow's milk allergy management. So please let your friends and colleagues know that there are these workshops coming up. Encourage them to join the workshops when you get notifications about them. Please share the information. The more we understand about cow's milk allergy, the better it will be for people living with cow's milk allergy. Thank you for your attendance today.